All right. So hello, everyone. Thank you for joining us today, May 3rd. This is our 153rd Kamwo Meetup that we've had so far, and it's pretty cool to keep on doing it. Sorry, let me just admit this one person in. And yeah, so thank you so much for joining us today. Some of you may know we do have a new Facebook group now that is called Kamwo Meetup. It's a private Facebook group since we moved from meetup.com to Facebook. And so yeah, so you can totally join us over there if you haven't done so. And I know some of you guys may not have Facebook, and that's totally fine. We also just created another group on Eventbrite called Kamwo Meetup as well. So you can join us over there to know more of the meetups that we have upcoming. And yeah, so right now I just want to just kind of go over just a few ground rules for today's meetup. So yes, everything is online. So we kindly ask that you keep your microphones on mute and feel free to raise your hand if you have any questions, but we will have a Q&A session after Josh's lecture to, 1 hour later on. So that's where I'll stop the recording and then you guys can feel free to do another Q&A session there. So, you don't have to have that pressure that, oh, I don't want to ask a question when it's on recording. So yeah, so there's that for you. And then so I'll just do a little short introduction of Josh and who he is. So Dr. Joshua Margolis has carved a distinguished career in treatment of chronic pain for over 2 decades as an acupuncturist and nearly 3 decades as a manual therapist. His rigorous academic background is highlighted by graduating from the Academy of Chinese Culture and Health Sciences in 2000, and his achieving of a diploma in osteopathic manual theory and practice from the Osteopathic College of Ontario in 2012. He is passionate about blending the rich traditions of Chinese medicine with the holistic, anatomically based principles of osteopathy to offer a nuanced approach to patient care. He excels as an educator. He is adept at distilling complexity into clear, comprehensible concepts, and his workshops and training sessions are celebrated for his dynamic style and the informative content and the practical tools they provide. And then, so right now, currently, Joshua is residing and practicing in Santa Rosa, California. And a fun fact about him is that he is obsessed with cats, and so am I. So we're both there. So yeah, so Josh, thank you so much for coming over here today. And yeah, I'll hand everything over to you now.
Uh, Thank you, and thank you so much for inviting me to be here. Can you all hear me? I just want to make sure you can hear me. Okay, great. In classic fashion, my voice decided to start leaving about 2 minutes before we went live, so bear with me. If you can't hear me, just ask me to repeat, and I will do my best. If you're wondering where the cats are, they're on the porch right outside, and I can see them. They're hiding under the, not hiding, they're keeping out of the sun. It's warm here in California right now. They're staying under the table on the porch. So they won't be joining us today, but thanks for your interest. I want to just pull this up. Okay, great. Can you see my slides there? We're pulling up. Okay, great. So just quickly about myself, I am both an acupuncturist and an osteopath. I have a practice in Santa Rosa, California, specializing in mostly chronic pain and some neurologic issues. I just was there this morning seeing patients, so really exciting to bring what I do in the clinic and share it with you. What you don't know, if many of you probably don't know what an osteopath is or what osteopathy is, and briefly, that's an anatomically based manual therapy system. In the United States, osteopaths are physicians, fully licensed, equal to MDs. Outside of the United States, osteopaths fill a similar role to chiropractors in the United States. And includes high velocity manipulation, but that's not the most commonly used thing. Probably most famous technique coming from osteopathy is craniosacral. So osteopathy in the cranial field. So my practice tends to be very gentle. I see a lot of very chronic pain, and I use acupuncture and osteopathy almost interchangeably in my practice. So I'd be happy to answer more questions about that. In this course, though, I want to present some concepts that are very near and dear to our hearts as osteopaths, which is using the manual therapy, using the development of the human being in utero as a blueprint for understanding how disease processes work. So this is not a new idea. We can give this back to Hua Tuo. He's the OG, original ganglionster. He came up with, he's credited with these points along the spine as alternates to the Back Shu points, which when you actually move closer to the spine, you're more accurate to their segmental innervation. So you're more likely targeting the vertebra and the nerves that you're trying to target than even just a 1.5 inch or so on the top of the longissimus muscle. So, this goes back to the very early days of Chinese medicine. And we know, like many of you, when I was an acupuncture student, it was sort of like the Hua Tuo points. It was kind of like, they just treat the organ that in that area that they innervate. Okay, next. And we just kind of moved on. These are actually some of the most important points that you've learned thus far. When I move the mouse, are you able to see my pointer, or do I need to put a pointer? You can see it? Okay, good. I just want to make sure. All right. This is a quote from the founder of osteopathy, that diseases are effects, the cause being a partial or complete failure of the nerves to properly conduct the fluid of life. And then I think this important concept, this is, was said about 125 years ago, 130 years ago by A.T. Still, the founder of osteopathy. And we tend to think of nerves as electrical conduits, but actually the current science has been showing that one of the things nerves do is transmit fluids, especially in a retrograde fashion. So from the spinal cord and from the dorsal root ganglion down along the pathway of the nerve to the target organ. So that's one of the ways that neurogenic inflammation, and these are terms we'll come back to quite a bit in this talk. So if you don't understand them now, we'll come back to it. And I think we're going to put up a link to the slides so that you can come back and review these later. Okay, so what is a segment? Okay, in embryology, it's called a somite, and you can see along the ridges here, these lumps, those are the somites, and somites are the divisions that will eventually become the segments themselves. Okay, so each somite is broken up into 3 main parts, which is a dermatome, which becomes the skin, the myotome, which becomes muscle, and the sclerotome, which becomes the bone, primarily of the ribs and the spine. We can break this up. We can look at these terms. It's a little confusing because this is how they're used embryologically, but we also use these terms to understand how pain is transmitted in the body and referred in the body. So you can have in the adult or, after birth, the dermatome is all the skin innervated by a particular nerve segment. The myotome are all the muscles innervated by a particular nerve segment, a neural segment, and the sclerotome are the bones. And so those did actually migrate off of the original sort of worm-like embryo to those places, and they drag their nerve supply with them. So they maintain interrelationships through the entire lifetime of the human, and all vertebrates, not just humans. Okay. So the nerves, we've seen these kind of dermatome maps before. This is probably a familiar picture. So nerves extend from the spinal cord to innervate each somite, okay? And so we can trace these back to understand what we're seeing. Now, a lot of clinical presentations can be described by these relationships. we mostly think about, in pain, most people think about the dermatomes, but actually for a lot of referrals are actually on the sclerotome, which is a little different map. And the dermatomes and the sclerotomes might not match topographically. And we'll see that in a moment in another slide. Okay, so this is an important concept to remember here, which is that every tissue remembers where it came from and the journey it took to arrive where you find it today. Okay, and then background here, we can see the somites along here, and you see the somites in a cross section here. These somites will send off the cells will migrate around to form the structures of the body ultimately. And so those will stay in relationship for the rest of life. So this slide is helpful to encapsulate what we're going to look at. So you'll pardon me, some of these slides I'm just going to whiz through because I really just want to give you a conceptual idea and where we're starting from. There's plenty more research. If you want to go into it, I'm happy. You can email me. I will happily give you more context and content to look at for sure. Okay, so we've talked about how there's an ongoing relationship for the derivatives within the segment. So everything that shares a segment, so that shares, say, C5 innervation, stays in relationship for the rest of our lives. Okay, that's in disease and that's in therapy. So acupuncture, one of its aspects is it's fundamentally a segmental input. Okay, so we can modulate the entire segment, change the functioning of things sharing the same innervation by putting a needle or multiple needles into structures derived from that segment. Okay, so we talked about how the segments drag their nerve supply along. Okay, so this makes for fairly predictable referral patterns. They're not always, but fairly predictable. Stress to a tissue within a segment can lower the threshold for all the tissues sharing the same segment. It's important to understand. So there's been plenty of tests, some really good ones actually by John Serbel, who's a Canadian chiropractor and PhD kinesiologist and neuroscience researcher. He's done some amazing segmental studies around showing how just putting capsaicin, like a little bit of an irritant, right, chili pepper oil on the skin can change how the muscles fire in the same dermatome, in the myotome, so from that same segment. And that's by stimulating the dermatome. He's shown that, there's differences in irritability and pressure sensitivity within the muscles that share the myotome, so that same segment from the dermatome and so on. Okay, and he's also shown some blood vessel changes, so the autonomics change. So the whole segment is always affected by other things happening in that segment. It's really a holistic concept. And I think very important to wrap your head around as we look into this. Okay, the plus side is, and not only do stressful inputs or potentially damaging inputs, which we're going to call noxious or nociceptive. We're going to talk about those more in a moment, but non-noxious stimuli, such as acupuncture, heat, pressure, massage, vibration, and so on, can also reduce the sensitivity within that whole segment. So acupuncture is one of the most powerful ways we have right now to neuromodulate the segment, okay? And this is really a key slide. So, come back to this one later. And if you have any, stop-worthy questions, do feel free and, you can let me know, Haiyong, if there's anything I need to look at, answer. So I'm going to dive into a little more into the specifics of some of the various layers of the embryo, and specifically we're going to be talking about this is going to be mostly a story of mesoderm, okay, which is the middle layer, and we're going to come to that in a moment as well. So the dermatome, you don't need to worry too much about where it's from, but becomes the dermis layer of skin. That's the living layer of your skin, right? Not the epithelium, but the living layer. Okay. And that provides sensation, and sympathetic innervation is very important for our temperature control. The myotome becomes the muscles. Okay. And that will become the muscles of the trunk and the limbs. And, of course, movement is a very important thing. And there's going to be motor and sensory innervation. And, it's going to be involved with movement primarily. The sclerotome is going to make our bones. Okay. In the strict embryologic sense, we're mostly talking about the vertebral column, ribs, and in the adult or the post natal population, as in people who are born, we're going to be talking about periosteum, bone, ligaments, and feces. And feces are the attachments of the tendon or ligaments to the bone. So these are very common areas where people have pain, right? Joint capsules, okay, the joints, so on. All of these things are sclerotomal. And this is a very overlooked region of the system for how to actually treat. I do a lot of periosteal pecking, where I actually purposefully peck the bone, and you can change the pain in the whole segment very, very quickly with that technique. Another aspect is the viscerotome. So this is going to be endodermal. So there's the ectoderm, mesoderm, and endoderm, which are the three layers of the trilaminar embryo as it's forming. And this becomes your guts, but really it becomes the linings of the guts, the epithelia, which are the ones that have secrete the fluids and so on, and the glands and so on. Many of these come from this layer. Sorry, the muscles themselves actually are, and the fascia support system of this actually come from the mesoderm. Now here's a segment, as I described before, kind of blown out. You can see here, so you guys can see my arrow? Yeah. Okay, just want to make sure. So here's a segment. We're just saying it's T5. Okay. So we're going to look at some nerves from T5, some neurons. We're going to send axons out here, up the spine, to come in and into the cervical spine, to synapse in a ganglia here, ganglion, in the sympathetic ganglion. And it's going to now go and innervate the blood vessels that might in the head and the eye. So it could change dilation and pupil reaction and so on. Might cause the eyelid to stay up higher. Okay, so we could have from T5 could be affecting the eyes. But T5 can also have a connection here, again, around a sympathetic and autonomic response to affect the heart. T5 also gets the intercostal muscles between the fourth and fifth rib. But then you can see here now that that's the myotome. So far we've done viscerotome, and now we're looking at the myotome. And then we're going to look at the dermatome, which in this case is actually shifted a little off. The dermatome for T5 can be a little bit lower than the myotome. So they don't always match. And in some areas of the body, this can be quite profound, the difference. Okay, does this make sense? So this is what we're talking about in an adult when we say a segment. All of the potential tissues that are innervated by a particular spinal cord level. So we're going to now do a crash course in embryology and look at how this kind of comes to be, so we can just at least conceptually talk about this and think about this. This stuff's very important when you're talking with other professionals. This is the foundation of chiropractic theory, a lot of osteopathic theory. pain science really is very segmentally oriented. There's a lot that's happening in the brain, but a lot happens at the spinal cord level. So this is important, and these kinds of discussions are great to have with professionals from other disciplines. So okay, so over here we're gonna look at the quick crash course in embryology, right? First you have one cell, then you have 2 cells, 4 cells, 8 cells, etc. As this process goes on, certain cells die off and certain cells migrate and so on, and you ultimately end up with this bilaminar disc by about 10 days after conception, okay, of fertilization. At that point, a few days later, what's going to happen is we're going to have some of these cells here. So this is going to become the ectoderm, and this is going to be the endoderm. So this is going to be your skin and nervous system, and this is going to become your gut linings. We have some cells that migrate from the ectoderm into between the primitive ectoderm into they force it their way into, and this is happening here, and become the mesoderm. So in the middle. So ecto means outside, endo means inside, meso means in the middle. So we have this movement of cells in here. At this time, you start getting an orientation sort of top to bottom. So this is the development of Ren and Du, right? It actually is the setting up, the front, the top of the body, the bottom of the body, and left and right sides. Okay. This is called gastrulation, if you want to get into it. But this is really where it happens, and those 3 layers come to be. Okay. Here's a cross section of this with the somites after the little further along in development. And so we have the neural tube. So the ectoderm is here, and it's starting to make a spinal cord. We have the ectoderm. This is going to become the skin. Ultimately, that'll seal off and then separate from the top. You have somites here. We have lateral plate and different aspects. There's 3 types of there's 3 aspects of the mesoderm, but we're going to focus on the somites. Somites become the vertebral column, vertebral muscles and so on. These ones are going to go on to form the limbs and the abdominal wall. This here is a very important structure called the notochord, which ultimately becomes our intervertebral discs. We do have a little, the nucleus pulposus, actually, the mushy part, the jelly center of the donuts in our spine. Those discs are from this notochord, and this notochord produces a lot of releases a lot of chemicals, signaling different aspects for development. So this is a very important concept here to understand, the somitogenesis. So I'm jumping through this kind of quickly, but I want you to kind of understand this. Okay, so by the end of the 5th week, we're going to already be developing into something that's more recognizable. We're going to as a vertebrate. Okay, so we have 7 craniosomidomeres, 4 pairs of occipital somites. So this is not really what we're going to be covering in the class, but this segmentation goes all the way up into our head. What you're going to see here is a pattern that's going to make some sense. We have 8 cervical somites, 12 thoracic somites, 5 lumbar, 5 sacral, and 8 to 10 coccygeal. So what happens is, if you see, look at the cervical, we have 8 cervical somites, we have 8 cervical nerves, 12 thoracic somites, 12 cervical nerves. We have 5 lumbar, 5 nerves, 5 sacral somites, 5 sacral nerves. The coccygeal in human beings, we reabsorb all the coccygeal ones but one, and so we have only 1 coccygeal nerve usually, most people, per side, and these are always paired. So this is always paired. So you can see here this is not necessarily a human. The pelvis is not quite right, but in the counts, there's like 6 lumbar vertebra here and so on. But this is same idea. And this is also how we're developed. So we have a cervical, we have the upper thoracics, which is and we have lower thoracics, which, when there's a split in the sympathetic nervous systems, when nerves from about T6 all tend to send their projections upwards, and nerves from T6 up all send their projections upwards, and nerves from T6 down tend to send their projections downwards. So T6 is a really interesting area for treating autonomic disorders and so on. You'll often find people with long-standing chronic pain and so on that the T6 spinous process, T7 spinous process in that area is very irritated, and it can be a generalized area to kind of affect a large region. Okay, so here are the somites forming again, and what happens is over here, the somites are starting to form. They form from top to bottom and bottom to top at the same time, and then it starts to zip. Oops, sorry. I'm going backwards. Wrong way. Okay, and you start to zip up from top to bottom, bottom to top. Okay, eventually you end up in the more classical embryo. And these are the part of the somatomeres, which become the pharyngeal arches, which become the face. But along here, the jaw mostly. Along here, you have the somites. Okay, and this is starting to look like a plan we recognize. We have limb buds starting to form, and so on. Okay, so. Is maybe before I jump off that, are there any specific questions anyone might have? Because we're going to take this as written that's what I'm going to cover for this.
I
You all
think
good?
one question in the chat box.
Yeah.
Says so needling locations can vary based on that location variation between thermal, scleral, and myo.
I'm sorry, what was that question?
I don't know. Do you see it on the chat box here? It might be.
Okay, so needling a coach. Oh, yeah. So that think of it this way: when you put a needle in, you might be hitting three or four different levels at the same time. So if you're trying to target one of the strategies for therapy, like, is trying to kind of flood one segment with acupuncture, so non-noxious stimulus, right? So you're saying someone has sciatica, right? That's like S1, S2 nerve root primarily. So that's those segments. So we might find that we can needle all kinds of different places to get S1, S2. So the sacroiliac joint innervated by S1, S2. Piriformis, also S1, S2. The hamstrings, S2, S2 to S3, some S1. Gastrocnemius, S1, S2. So that's just muscles. Then you can go down to the lateral malleolus or the calcaneus. They're trying to tap the bone. You can look at the bottom of the feet, some of the so on. And depending on your depth, you're going to get different levels. So one example is spleen 6 being a classic point to deal with, like, the lower abdomen, right? So the parasympathetic innervation for the bladder and the uterus or the prostate, so the genitourinary system, is primarily S1, S2. Okay, S2 is kind of the underlined one, but S2 through 4. But if you're superficial on spleen 6, you're going to be on the L4 dermatome. Yeah. So, but if you go deeper, you're getting right into the tibial nerve, and you're getting into the deep flexors, the like toe flexors and so on. Those are S1, S2. So if you're just do like superficial needling, kind of a Japanese style or so on, you're not actually going to affect that segment. Does that make sense? There's like drift because as the development happens, different tissues migrate at different speeds. If you needle in the back, for example, right, you go through latissimus dorsi. Anyone know what the innervation for latissimus dorsi is? Like C6 to C8. So you can be way down the back. And if you do superficial needling, you're going to go through skin that might be like T10, and then you're going to suddenly be in C6 to C8 territory. And then if you go deeper, you're going to be in somewhere else. If you're going through the traps and you're really superficial, you're going to go through the skin. It's going to be somewhat related to the segment of the vertebra. But if you're just in that first layer of muscle, you're really affecting cervical segments. Does that make sense? Because it just doesn't always line up how things move, because the way the limbs grow, especially with limb muscles, the limb muscles are they go out to the limbs and then they like grow back onto the spine and reattach. So it comes on later. It's like, sedimentary formation. Does that make sense? So you kind of have to think, when you start thinking three-dimensionally about where your needle's going, what you're really trying to target, and pay attention to your depth. And that'll get you in the right segment. Okay. Uh, Sclerotome, yeah. So good books. Um, Holland's Heads, I is good. Um, there's there's segmental stuff. The sclerotomal in particular, the research is a little newer and less refined, and there's, I think, more variation from person to person. And the dermatome charts are like, if you look at 10 different dermatome charts, there'll be quite a bit of variance as to where they're located. And there's a lot of overlap and redundancy in the system. So it's okay. I mean, you just need to get in the area. And what you're going to look for are what we've always done, if you palpate, are tender spots in that area. So if you're interested in treating the dermatome, you can pinch and roll, just like a light pinch and roll through that dermatome, and you go, oh gosh, I feel this like thickening and it's tender, and the patient goes, then you can throw superficial needles in that area and you can treat that dermatome. If you're looking for trigger points, right, you look for tender points, or usher points. If you're not a trigger point person, you look for tender spots or top bands. You find that spot, patient goes, sure, yes, that's it, and you needle that. If you're looking for sclerotomal stuff, you just need to look for attachments like at the entheses, so the tendon ligament attachments, or the muscle attachments, or along joint lines, and so on. So it doesn't have to be very complex. Just if you have a good overview of the map, because there's redundancy, ask the patient's body, interrogate the segment, ask it, it'll tell you. And then when you start to see, is there a good segmental pattern, like, wow, gosh, I push on the medial malleolus and it's really tender. Okay, that's like L4, right? Then like, oh, that patient has knee pain, et cetera, et cetera. So you can start to kind of jam around in these things. Like I saw a patient today, and uh, he had medial knee pain. So medial knee pain is usually related to the saphenous nerve, L3, L4 mostly. So I palpated down in the area of liver 5. Liver 5, I found subcutaneous swelling, irritation. I put one needle in there, manually stemmed it a little bit, and before treatment at about 110 degrees of flexion, patient was wincing, had pain, was uncomfortable. After 10 seconds of stimulation at like liver 5 area, by palpation in that area, he had pain-free, full passive flexion with overpressure. So you can use these things very dynamically in the clinic. It doesn't have, don't get too hung up on the details. It's like, start to understand how it fits, and you'll find more and more ways to do this. I'll come back to your question later, Emily, if you don't mind. Okay. All right. So let's look a little bit at how segmentation works in the postnatal population. Okay. So the first thing we want to do is just review the anatomy. Okay. So this is a spinal cord. This is the posterior, the back part, the anterior part. Okay. This is the white matter where the wires travel, the myelinated area. And this is the gray portion, the butterfly here, which is where we have the cell bodies. Okay. So we call these sections here where it protrudes horns. So you have a posterior horn, lateral horn, and an anterior horn. Okay. That's what they're called. I don't know why they don't look like horns to me either, but that's what they're called. So the posterior horn is where sensory neurons interface with spinal neurons. So the sensory neurons, they come in the back, and then they will go on a path. I'll tell you about that later. On the lateral horn, so this is sensory area. Over here is, this part is where we get, this is where we get more of the nociception and so on. There's some breakup in somatic and visceral. It's not perfect, all this stuff. In the lateral horn, this is where the autonomic, sympathetic neurons live. And this is only in T1 to L2 approximately. There's some variance. Some people C8 to L3, just depends, but it's close enough. And then in the anterior horn is where we have the motor neurons. So these are going to control the muscles in the body. So here we have the dorsal root, and the dorsal root right here, this is the dorsal root ganglion. This is where the cell bodies of sensory nerves that innervate the rest of the body they live here. And so they kind of have like they're like a T shape. So they're going to send a projection off this way and a projection off this way. So, you know, a nerve that goes to your like tip of your toe is going to have its body here, and it's going to send a long projection all the way down to your toe. And then that information will come up here. And then it'll get transmitted over here. And we'll talk about what happens there a little bit. But this is the quick layout. And then motor information from both the lateral horn and the ventral horn will travel out along the ventral root here. Okay. So motor for the autonomic nervous system is what? How fast your muscles of your guts move, sweating, things like that. Okay, so we have a spinal nerve here. The spinal cord is always a lot smaller than you think it is in real life, especially in the thoracic spine and the lumbar spine, because the intricacies of what it needs to control are quite a bit smaller. But we have the 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and a coccygeal nerve. So the peripheral nervous system is everything outside the brain and spinal cord. Okay, that's a quick, dirty definition. So we have the somatic nervous system, which is sensation and motor control for the limbs and all the skeletal muscles, facial muscles, and so on. And we have the autonomic nervous system, which controls involuntary responses and regulates physiological function. So the somatic nervous system is really responsible for the striated muscles, and the autonomic is for the smooth muscles, right? That makes sense? And cardiac muscle. Cardiac muscle is also under control of the autonomic nervous system. Okay. In the back here, these are sympathetic ganglia, which are, ganglion means like a knot, and it's where a lot of cell bodies are. And so that's an area that we see a lot. Okay, so here's a quick slide kind of summarizing the autonomic nervous system, and this kind of cool graphic I found this morning. This slide was a last minute addition this morning. Kind of symbolically shows some of the innervation levels for the in the sympathetic nervous system. So couple key things to know about the autonomics are that they synapse with another neuron before entering their target tissue. So they don't just go, so like, you know, a nerve from T5 doesn't just go straight to your stomach. It will go somewhere, talk to another nerve, which will actually go to talk to the stomach. Okay. And that always happens in both the sympathetic and the parasympathetic nervous systems, which are the 2 divisions of the autonomic nervous system. So I won't be talking about parasympathetic and the vagus nerve in this class because we're looking at the segmental portion. Okay. So they're going to control involuntary emotion, okay, heart rate. It's going to control peristalsis rate, sweating, pupil dilation, etc. Okay, so smooth muscles, and it's going to control glands. So, you know, when you're under stress, your motility in your guts goes down. The you know, your pupils dilate, you know, you stop making as many gastric secretions. All these things are to prepare you for a fight or flight response, right? Sympathetic being the fight or flight. So that also includes dilating the arteries to the extremities while constricting the arteries that go to the guts, right? So all of these things work together. You constrict the blood vessels in the skin because what happens if a tiger bites you? You know, you're not going to bleed. You're not going to bleed as much. So this is all for survival. So sympathetic nervous system is related to the fight or flight, T1 to T1 to L2 or so. And they tend to have a short preganglionic fiber. So before it synapses, they tend to go a short distance, and then they will synapse. Synapse means one neuron talking to another. Okay. They may travel up or down. You can see, I don't know if you can see this in here, but they kind of come out and then it kind of goes up. And so, you know, you do have sympathetic ganglia above and below the levels that the nerve, the origin, the actual segment that the nerve originates from. It may travel here from like L1, L2 down into the sacral ganglia before going into the pelvis, into the bladder or the rectum or something like that. Okay. So this is norepinephrine. Okay, this is called the thoracolumbar nervous system sometimes, to be contrasted from the craniosacral nervous system, which is the parasympathetic. Okay. So everything that we're going to see in the sympathetic is to prepare the body for action and defense. Now here we can see overlaid some of the dermatomes with what's sort of called heads zones, which are common referral areas for when the organ's in trouble. You'll commonly see these kinds of referrals. This is not the thing with sympathetic type mediated pain is that it is often more indistinct and a little harder to localize. It can be quite strong, but it's also quite it's harder to localize. So it's hard to see where that comes from. So that's, you know, for example, like here you see the diaphragm C4 up into the top of the shoulder. That's the phrenic nerve, right? Phrenic nerve that innervates the diaphragm. The phrenic nerve also innervates like the capsule of the liver and the stomach and gallbladder even. And so that's part of why you get this like shoulder and neck pain related to the liver and gallbladder, even in Western medicine, right? We know that often people feel the pain in their shoulders. It's not uncommon. And you can see here's a schema of a sympathetic ganglion. So here we have information coming in. So say from a dermatome, this is going up here to sensation. It's actually giving a little branch off here, and we can see this connection. So this is going through a ganglion. Some will synapse closer to their target organ. Some will synapse closer to like in the sympathetic ganglion itself. So they'll always travel through it. There's a white and a gray ramus here, which contain those. So you see how this one comes around and makes a loop. Yeah, so that's how that happens. A lot of the sensory information on the from the organs is on unmyelinated C fibers. So that's kind of interesting. Okay. So let's talk a little bit about different types of segmental acupuncture and how we can apply this in real world in the clinic. Okay. So you can stimulate any tissue in the segment to affect the rest of the segment. Okay. So you have lots of options here. I'll break that down a little bit more. So we can needle other tissues in the same segment. So you can put more than one needle in the same painful area, for example. You can needle the biceps or deltoid for the biceps, for example, because the deltoid also shares C5, C6 innervation, just like the biceps does. You could needle, like I gave you this example before, where you have the connection for the the malleolus, the piriformis, and the sural nerve, and so on, which is a cutaneous nerve, that all share the same S1, S2 innervation to treat any problem in any of those. Okay. Needling contralateral derivatives. So segments actually can communicate across. So you can needle the left to right. This is very classical acupuncture, right? So you can see that sometimes pain problems will evolve and someone will have a phantom pain. Oh, I think I must be favoring my left knee because, my right knee's been hurting so long. They may actually be having segmental crosstalk and now their left knee hurts and there's no problem in the left knee. So you can treat that way too. And you can needle axial and peripheral derivatives at the same time, which means that you're talking about, needling spinal tissues to affect peripheral tissues, so like in the limbs and vice versa. So this is like very much what we think in acupuncture, right? Use bladder 60 or small intestine 3 to affect the back, right? So here it's just broken out in kind of in some a little more detail, but you can go spinal tissues to treat spinal tissues, axial meaning the spine and the spine and ribs. You can do axial to peripheral, so you can use the Hua Tuo Jia Ji to treat limb problems. You can go peripheral to peripheral, one limb to treat the other, more needles in the same limb, different layers, different aspects of the segment. And you can go peripheral to axial. So you can use peripheral points to treat spinal problems, right? Okay. But the axial inputs tend to actually be a bit stronger and more effective. All right, so here are a few types of acupuncture, segmental acupuncture, just examples of ways you can do this. So you can like try to target the dermatome directly. So this is cutaneous nerve stimulation. You can see in this picture, there's needles kind of going along those cutaneous nerves, right? I talked about that using that liver 5 area for medial knee pain, which I do a lot, works well. You can do intramuscular stimulation. This is Si Chan Gun, who is famous for developing this, which is essentially trigger point and motor point needling, which many of you probably do already, but then adding in treating the segment, so treating the multifidus muscle at those levels that are affected. And there's some ways we can look at that, and I'll talk about how to assess a segment in a little bit. There's periosteal pecking and osteopuncture, which are essentially finding, areas on the bone or ligament and needling those. Periosteal pecking is a manual stimulation, and osteopuncture is a high frequency electrical stimulation applied to those tissues. And those tend to be where they're closer to the surface because it's really hard to, you'd be surprised at how hard it is to hit bone on purpose sometimes. Your needle bends and so on. So these tend to be trying to get sites that are pretty easy to hit. And certainly for the electrical stim, it's not very comfortable if you go high frequency through muscle. It can cause a lot of cramping and so on. So visceral autonomic modulation, vascular sympathetic modulation. This is just using the sympathetic innervation for, say, the limbs to try to treat more chronic issues where you want to affect the circulatory system. And this is using low frequency electrical stimulation. And then there's PENS, Craig PENS, which is developed by Bill Craig, which is uses progressively higher frequencies from axial from the spine going peripherally. The more lateral or distal you go from the spine, the higher frequencies you're using. And you might have 2 to 4 modules going at different frequencies. This is kind of a cumbersome technique, but it's a good shotgun technique. Doesn't require a lot of assessment, and you cover a lot of ground with it. Okay. So those are things that, if you came and took a class, we'd talk about them in quite a bit more detail, but just those are representative kind of modern medical acupuncture approaches to acupuncture. So we got to talk a little bit about pain. And then maybe I'll stop for questions again, and then we'll go on and wrap things up. Okay, so pain is a unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This is a really important sentence. So pain is by its nature is unpleasant. Okay. It can be caused by things that actually cause damage, and it can be caused by things that might cause damage. So, for example, water gets up over about 120 degrees, it starts to hurt. You're not going to actually damage your tissue at 124 degrees. Might not feel good, but you're going to might get a withdrawal. You get up to 130, no way. You get higher than that, you start burning yourself, right? So your system already is calibrated to keep you away from potential damage. And a lot of this is processed in the anterior cingulate gyrus, which is is related to it's not the ACG, it's the insula. Sorry, it's processed in the insula, which is where our a lot of our emotional processing is processed. So nociceptors, the C fibers especially, they all have terminations. They have all synapse a lot with our emotional brain, right? You know, pain. You're never in a good mood. You feel tired. You feel achy. You don't want to deal with the things. You know, you hate your partner, all that stuff. You know, and they didn't do anything. You just hurt your knee, right? So nociception is something, so could be mechanical, thermal, or chemical event that has that potential to cause tissue damage. Okay, and we have small caliber of fibers here. Pain is the perception and the organization of it in the head, right? So it's a little different. So not all nociception is painful. So for example, have you seen those studies that like by 70 years old, like 80 to 90% of asymptomatic people, people without back pain have degenerative discs and arthritis and so on, right? We've all seen those patients who have terrible looking arthritis and they have no pain. So they're having nociception. That inflammation is happening, the irritation in the segment is happening, but it's not crossing a certain line to be interpreted as pain, right? You know, those tennis players, you see those things like people like break their ankle, and then like go on to win the open or whatever. They're having tons of nociception, but their top-down control they're in that game. They're like, no way, I practiced too hard. I'm not going to lose this. They don't feel pain until afterwards. So pain and nociception, that potential tissue damage and the actual emotional aspect of it, or the processing aspect of it, are not always at the same time or are always there. So we have three main types of pain. We have nociceptive pain, neuropathic pain, and nociplastic pain. Nociceptive pain is from tissue damage or potential tissue damage. Neuropathic pain is from irritation to the nerve. And nociplastic pain is when the central nervous system has become sensitized and won't let it go. So that the nervous system actually starts producing, it becomes more sensitive to input and mischaracterizes some sensations as pain. So I'll leave those for you to look at. There's three types of nerve fibers that we want to talk about in relationship to this, which are A deltas, C fibers, and A betas. So this little thing is to help you kind of visually understand how big they are and how much myelin they have. So myelin being the insulation. So C fibers are unmyelinated. These are dull pain, slower pain. A delta, and very small. A deltas are a little larger and they deal with pain. A lot of acupuncture sensation is transmitted by the A delta fibers. And they are partially myelinated, a little larger fiber. And these A betas and A alphas, which we're not going to talk about in this lecture, are heavily myelinated and going on. There's some people texting me here, so I want to just make sure they're not. You guys can hear me? Yeah? Okay. So maybe we can stop for questions before I process this a little more. I know we're coming up towards the end, but we're gonna make it. So Do you guys want to pop anything up in the chat box? So how long the results last in the knee pain? That's a good question. That depends on the chronicity and how well you can deal with the underlying condition. So for that patient who has that I was talking about, that might last 10 minutes or it might last a day, a couple days, few days, just from that light stimulation. So we might want to increase the dosage. So electrical stim or more manual stim or more needles in the same segment, give him herbs or other anti-inflammatory things to deal with the arthritis. His big toe is fixated, so trying to get his big toe to move better because he plays petanque, which is kind of like bocce ball. So he's always kneeling down and trying to, his big toe doesn't bend, so he like ends up putting way more force into his knee. So you got to look kind of at all the factors before you just call it that. Okay. So that's not easy to answer, but it's kind of like it's the Chinese medicine, the answer to everything, right? It depends. Um, is there a system of progression? Which one to try first? Okay, yeah. I mean, yes, I guess the answer is there a progression? You have to kind of look where the patient is at. If the patient is very sensitized, I mean, has anyone needled a patient and made them worse? Right? Their pain gets so much worse. Never had that experience? No, it happens a lot. So if you're in the wrong, like if you have a very sensitized patient and you start stimulating, like I'm going to do trigger point needling or Usher needling, strong needling, you're going to likely to blow them out of the water. So that patient, I often do cutaneous needling, maybe just touch the edge of the muscle, and that's enough. Right? If that patient, I mean, it's like if they're so acute, I mean, right? Distal acupuncture works so well, right? Someone sprains their neck in a car, he gets a car injury, light needles, boom, doesn't hurt, right? But for that chronic patient, that often doesn't work, where it's like settled in the compensations. You might have to target more layers and have a more comprehensive approach. Okay. Again, it depends. Okay. So we're going to just look at this super briefly. So this is the non-pain pathway, and you're going to see that for non-painful stimuli, a large diameter like A beta fiber will be stimulated, and the sensory neuron, it might synapse here, but the main thing it's going to do is going to go over, cross over, go through the thalamus, and go into the somatosensory cortex. For a nociceptive input, it's going to, here's the cell body, similar area. This is going to be a C fiber or AU delta. It is going to synapse. They always do. It crosses over down in the spine and then heads up the thalamus and somatosensory cortex and the insula, actually. But what happens is you see this little terminal, which is related to pain. There's this little bit here where if you stimulate a large diameter fiber, it will stimulate an interneuron that releases GABA. And what GABA is an inhibitory neurotransmitter, and this will set up the gate. It happens in the spinal cord. So this is the classic, anyone ever, you bump your elbow really hard, and then what's the first thing you do, right? You rub it. So this vibration and stretching goes on those larger diameter nerve fibers. And so that message gets to the spinal cord first, says, oh, it's just rubbing and stretching. And so it actually goes, no danger, and it reduces the amount of pain that is transmitted and perceived from here. It actually blocks those nociceptive signals from getting to the brain in the first place. Okay. This is part of how acupuncture works. It's how vibration, stretching, pressure massage, all these things all have this as part of their function. Acupuncture as well. Okay. So trigger points are probably more of a result of central sensitization, which is actually the ramping up of the nervous system. If it gets nociceptive inputs for too long, it's going to become more sensitized, and it actually will have a bigger response, a longer response, and a response from less input. And it can actually go to the point where light pressure and so on become painful, right? So those large diameter non-nociceptive neurons will start acting like nociceptors and give pain, and the brain will start to interpret light touch or even no touch as pain. Okay. So that this concept here of central sensitization is really important to understand. And the three things we're going to look for: hyperalgesia, which is too much pain from a lightly painful stimulus; allodynia, which is pain from a non-painful stimulus; and expansion of the receptive field. So literally a nerve, which will have an area that it's sort of, this is what I pay attention to, this little corner of your knee, but it will start to spread out and actually take input and fire from stimulus that's quite far away from its normal receptive field. So it'll take less to make more. Okay. So these are what we're going to look like for in the clinic. So how does this really happen in the clinic is that the dorsal horn neurons, the sensory neurons uh, uh, the sensory neurons become damaged, and they stop like having that ability to inhibit those nociceptive messages. So you're going to have hyperalgesia and allodynia. And so that sensitization can spread. And this happens really from this guy smacking at that area for a long time. So that could be an arthritic disc, that could an arthritic joint, it could be a spinal disc, it could be you have a pair of shoes that doesn't fit you well. It could be, inflammatory bowel disease. It could be all of those things. And so you have to try to find out who is like hitting the nervous system. And that's why I responded before is, it depends what you do. If you can figure out what the thing that's irritating the nervous system the most, you have a better chance of down-regulating that whole segment rather than just treating the echoes in the segment. Okay, so this ultimately ends up a dumpster fire where the nervous system becomes very sensitized. So you start to have what we call suprasegmental effects, right? They're happening in the brain. So you have fear and anxiety, poor concentration, insomnia, uh, taking on the roles as a sick person, pain catastrophizing. This is really big. Like, oh, I can't go on that camping trip. That my knee will really break. And you're like, but there's nothing wrong really with the knee at that point. It's really that the nervous system itself has become unregulated and it's not able to downregulate the sensation from the knee and differentiate between painful and non-painful, or not nociceptive and non-nociceptive. It's still hard. I've done working with this for a long time sometimes to keep the nociceptive versus pain, but that crossover from nociception into pain is really important. So pain catastrophizing and its sensitivity to sensory input. And this is actually all sensitivity. So you may have noticed with people who have really chronic pain is that they're like, can you turn the music down? Can you turn that light down? Oh, the temperature is a little off here. Did you guys use a new cleaning chemical? Something smells in here, right? They actually become sensitized in all their senses, because this is happening throughout the whole nervous system. So even one trigger point they've shown, Jay Shah did a fantastic study showing inflammatory chemicals throughout the entire body were higher, substance P, CGRP, and glutamate for people who have just a single trigger point in the trapezius. Okay, so that this is a systemic event. Okay, so the key things we're going to look for in the clinic are allodynia, which is pain where there shouldn't be pain. Okay, so in the spine or in the periphery, we can detect the dermatome by doing a pinch and roll test. So that's kind of just rolling the skin like that. You can also do that on the extremities. You can, when you go like, it's the classic thing where a patient goes, God, that hurts, stop pushing so hard. And you're like, I barely touched you. That's allodynia, right? Hyperalgesia is a little different. Allodynia is like stage 2. Hyperalgesia is more pain from something that is already a little that is nociceptive, that's unpainful. So there could be sensitivity to heat. That could be, oh, I'm pressing hard, or, they're straining something. They're going to have some pain. So that's like the Wartenberg, the pinwheel. Do you guys ever use the pinwheel in your neuro testing? You can just take a paper clip and scratch again along the skin. I use the Tsumoshin, which is like like a retractable ear probe. It's kind of great because it's exactly 200 grams of pressure. So it gives me a very predictable input so that I can go like, did I press the same? Okay, and then we're going to have that expansion of the pain. So we're going to you can test the dermatomes and the myotomes and the sclerotomes pretty quickly with these techniques. Quickly on this one here, this is kind of the key to the whole thing. Okay, so we have these arrows coming in. So coming in, we have input, right? So say we have irritation on the left side of this patient's spine, right? So it's coming in, talking to the dorsal horn here, right? Now we start sending inputs out, altered inputs. They're going to be higher. We're going to have altered sympathetic inputs. So we're going to see in that same dermatome, we're going to see constriction. So sympathetic constriction of the vasculature, the superficial vasculature and the lymphatics, which will make the pinch and roll. The skin will become very thick and painful to move. We're going to see sweating changes. Those are autonomic changes. So the electrical resistance will go down. We might see goosebumps. We might see intestinal problems and so on. And then we could see also, say this is L4, we can see it switch to the opposite side. We can see it move up and down. We can see it go to the knee joint or the knee, the quadriceps. So they can have pain here, right? This is sclerotomal. Oops. This here is sclerotomal, myotomal, visceral tomal, dermatomal. And so we can have spread throughout the whole system. And once you have this irritation on all of these, they are now sending feedback back along this orange line here. This red line is something we call the dorsal. This is actually going along the sensory nerves. There's a retrograde, so against the flow of the nerve. We normally think sensory nerves are going from the periphery into the spinal cord. We can have a retrograde flow of chemicals like substance P, CGRP, glutamate, and so on along the flow going backwards. So we actually, this is what neurogenic, means nerve controlled neurogenic inflammation. So we get nerve generated nerve generated inflammation. So we have this sterile internal inflammatory cycle where then that reduces the threshold for irritation in the periphery, which then loops back and reduces the threshold in the at the spinal cord level, etc. So everything becomes disinhibited. And over time, what can happen is you can get to the point where it just hurts on its own. You don't have to even do anything. And this is the same thing that happens in a lot of visceral disorders, like irritable bowel syndrome operates on the same in the same way, interstitial cystitis, and so on. All of these things operate kind of pretty similarly to this. Okay, so what do we do about it? So we got to figure out what's causing the pain. So we got to find out what the original causes. So if you can figure out, like in the arthritic knee, we do have to deal with the arthritic knee. I can neuromodulate the pain, but it might not fix it on its own. We have to check in the rest of the dermatomes, myotomes, and sclerotomes for changes in that same segment. We can do treatments. Acupuncture is one of the best. And then we got to change how the patient's doing things. So is there something they're doing that's exacerbating this over and over again? So this guy who plays petanque, he stopped kneeling. He just had to relearn how to pitch. It was hard for him, but he's not, he's learning how to do that. So here are those signs. This is trophodema. So these are different signs. This is the matchstick test on the left, where you're just using like the back of the tube, your acupuncture tube. You can, if you press down for a few seconds and it leaves a mark, that's a sign that there's edema under the skin. These are the pinch and rolls on the far right. And in the middle is that peau d'orange, which is when you press on the area, you can see on the left, right around in here, you see those, how the hair follicles are really demarcated. That's because there's subcutaneous edema. So you can feel all of this stuff. there's also going to be increased histamine response and sweating because of the higher sympathetic activity in the segment. So you can, by vigorously rubbing, you'll see more redness, or redness will stay for longer. And you can, this is on the right, this is a skin drag test where you just very lightly roll your fingers over the areas, and your fingers will just stop in the right area. So what do? We just needle the Hua Tuo Jia Ji. So all of this was to say, come around, we're going to needle the Hua Tuo Jia Ji and potentially other tissues within that same segment. But you get a lot of bang for your buck needling just the Hua Tuo Jia Ji. Okay. So you can retain it, you can do electrical stem, you can do all kinds of things here. But I try to be very, very close to the spinous process, almost just off it, almost not even into the multifidus. Just there's like this little groove. So if you can kind of slide in there, just lateral to the spinous process, that's kind of a sweet spot where you can get some really good stimulation without a lot of pain, and activating nociception. You can also needle the due meridian, or just along there. So here, this shows needling into interspinous ligaments, or even pecking on the spinous process. This is showing kind of that area I'm talking about, where you're really literally just off the edge. Or you can also peck the sides of the bone there to get the periosteum, the sclerotome. Okay. And my last thought for you is, to find health should be the object of the doctor. Anyone can find disease. So, we want to figure out how we can help the patient's nervous system heal itself, right? That's what acupuncture does. We don't heal anybody. We make it possible for their nervous system to have a more normal response, to re-regulate. And so understanding these kinds of reflexes and interactions is a way that we can do that, I think, much, much more easily. And no matter what style, if you're looking at how distal relationships, if you're looking at distal acupuncture type relationships and so on, you can see many of them have a segmental effect. There's a lot, and that's something we can talk about more, but I don't want to take up too much of your evening there. I know a lot of you, it's late. So final thoughts is that I will be in New York actually next month with the Tao Collective, teaching in person. So we have a 3-day course where we dive into all of this stuff in much more detail and show specifically how to do these things. And the assessment part really is the thing. It's really hard to show in this context online and here, but it's really the thing, because there's a lot of different ways to treat, and you will find your own way there. So I will be in New York, I think it's June 7th through 9th. And I think Hayoung just put up the link, so it's at the daocollective.com, dao-collective.com. And that's all I have to say. So now I want to make sure that you guys have time to ask me questions and anything. So thanks for hanging in with me.
Yeah. Oh my gosh. Thank you so much, Joshua, for everything. Such a great lecture. And yeah, please check out his workshop. It looks very, very interesting already. I would love to learn more. And yeah, the early bird rate is still active. So thank you, Dodie, for saying that. Yeah, I saw it. So yeah, it's 975, I believe, instead of the regular 1200. So yeah, definitely check it out. And then so yeah, I just want to before we stop the recording and go into the Q&A session, just want to say thank you again for everyone for coming in and tuning in with us. You will get a $20 like eScript voucher, like a voucher to the eScript Pro Shop in the next few days when I go back into office next week. So yeah, so thank you so much. And then yeah, we will. Oh, and then we also have a next meetup coming up, is with Henry McCann. I believe is next Friday on May 10th, and that one is actually going to be in person. If you can't come in person, we will have a live simulcast option there, and he will be talking about Deng's acupuncture and distant point needling. So that'll be also a fun one to tune into. So okay, so I'll say thank you so much again. I'll stop the recording, and then we'll go into the Q&A session.